This is Professor Michael Chapman. I'm one of the most experienced IVF doctors in Australia. I believe that an important part that I can contribute is to educate patients in relation to fertility, infertility, and all that involves. These series of podcasts help to educate you. I hope they are helpful to you. If you wish to know more, however, I'm more than happy to have you contact me via email, which is profmchapman@gmail.com, or make an appointment to see me on 9138 4222.
First question is from Casey. She says, "Hi, Prof. I'm 34 years old. I have one 3-year-old who was conceived naturally on the first cycle. I had a traumatic birth with my daughter that caused Asherman's syndrome from retained placenta. Prof. Van Sale treated my Asherman's last year, stage 1 cleared. I still have light periods and started IVF. I got 3 embryos, both transferred with PRP treatment, sperm good. They said my lining is good. My second cycle in September, I fell pregnant, but resulting in a cornual ectopic treated with direct MTX shot to embryo. Previous history of an ectopic. I have 1 embryo left. What do you think my chances are of conceiving?"
The corneal ectopic, it may be, and Thierry Van Kai is, the best in Australia in terms of treating Asherman syndrome. I'm sure he's done his best to produce a uterus which is suitable for a pregnancy. The corneal ectopic suggests that the best area of the uterus for an implant was the area that wouldn't have been necessarily affected by the Ashermans, which makes me a little nervous about the rest of the uterus. Before embarking on another treatment, I think I'd like to assess the endometrium in the second half of the cycle by detailed ultrasound to just see that basically the fertile area is in good shape. I'm not totally convinced about the PRP treatment. I know Thierry is very positive about it, but randomised controlled trials have not shown it to be of significant benefit, but it does no harm, so therefore it's probably worth doing. It really comes down to what state your uterus is in at the moment as to the chances of a pregnancy occurring. And that's probably where, and without detailed information about your uterus at the moment, as far as I would go. But I wouldn't lose hope. I've certainly seen pregnancies in that sort of scenario.
We have a question from Dee Dee. She says, "Can I get a booster while pregnant?"
Absolutely. Yep, no problem whatsoever.
Sheila asks, "Hi, Prof. I had a miscarriage and they tested the tissue and found no chromosome issue and it was normal. Are there any other issues that cause miscarriage or anything I need to check on? I have adenomyosis." Sorry.
Adenomyosis. Yeah, adenomyosis normally doesn't cause miscarriage. It's not a reason for a miscarriage. It can be a factor in not getting pregnant, but not really associated with miscarriage as such. 60% of miscarriages in women under the age of 40 are caused by genetic abnormalities. And what you found is that you're in the 40% that is not the case. After one miscarriage, we generally don't go into detailed assessment. However, now that we've found that there was a genetically normal embryo, it probably tilts the scale towards looking further. So the things that can cause or be associated with miscarriage is the uterus itself, the anatomy of the uterus. Have you got fibroids that are bulging into the cavity of the uterus? So a detailed ultrasound of your uterus is useful. The other anatomical part that is vital in implantation is the lining of the womb. And so there is a very small group of patients in whom there is long-term chronic inflammation called endometritis. And that's really only discovered by taking a sample of the lining of the womb. After one miscarriage, I wouldn't recommend having a hysteroscopy, that's looking inside with a telescope, unless an ultrasound suggests that there were problems. But that would be certainly after 2 miscarriages, I do recommend having that. The other aspects of a pregnancy being retained by the body is the immune reaction between the pregnancy and yourself. In the normal situation with an ongoing pregnancy, your immune system, unusually, and we still don't understand quite how it works, tolerates the fact that there is something inside you that actually is foreign. The genetic material from your partner's sperm is foreign to the woman's body. And normally when the human body sees things that are foreign, they mount an immune response to get rid of it. It's why infections give you immunity because your body has built antibodies against it. But for some reason in the human, we tolerate that genetic difference. However, whatever that process is, if it goes wrong, it's possible that your body rejects the pregnancy on an immunological basis. To investigate that, we can do a blood test that looks for some diseases which have a heightened risk of that immune activity. They're called autoimmune diseases. There's something called lupus, is a disease that affects young women. It's not very common. But we know that miscarriage rates are higher in that particular group, and they may not have clinical signs of lupus. So there's a blood test, 2 or 3 of this in the same area, that can help determine whether you've got that problem. There is some evidence that, although not strong evidence, that something called natural killer cells, which are normal in an immune response, might be exaggerated in women who have miscarriages on a regular basis. As I said, the science is not strong, but if we find an elevated level of these cells or those autoimmune diseases, we can treat it by using prednisolone, a steroid, to suppress those cells during the first 12 weeks of pregnancy. The last area in relation to the interaction of the mother and the pregnancy is a tendency towards blood clotting. So some women have a tendency towards blood clotting. If you've had a thrombosis before, it may be that you have a tendency towards blood clotting. There is also some evidence that women with those factors that increase the blood clotting may produce miscarriage, basically by causing a blood clot in the tiny little blood vessels that the placenta is, and therefore sort of blocking off blood supply to the embryo and therefore causing a miscarriage. Again, a blood test can give us some idea that if that's the case, and more importantly, if we find that tendency, we can try and avoid it by giving blood thinners, either aspirin or injections on a daily basis, blood thinner called Clexane. So there are a number of things to go looking for when we don't get or we have a miscarriage when there isn't a chromosome abnormality. If you were worried about the future, and it's obviously you're asking the question, so you are, I'd be happy to see you and take you through that gamut of tests. I do Zoom consults. I see face-to-face consults in Cogra at St George Private, where my clinic is, but I also am happy to do Zoom consults. You can make an appointment to do that by just ringing the rooms at Cogra, which is 9598 5505, 9598 5505. And we can have a further conversation if you want. But by the way, what we know from the last 100 years of research about miscarriage is that after one miscarriage, which if you were 35 years old, for instance, one miscarriage, next time your odds of a miscarriage are just the same. 1 in 6 is still 1 in 6 after the first one. 1 in 6 after the second one. It's only when you get to 3 or 4 miscarriages that it increases to 1 in 4, which means if you look at that statistic, the next pregnancy that you have after your first miscarriage is an 85% chance you will have a normal pregnancy without me doing anything. If we do all those tests that I outlined to you, there's probably a 5% chance of me finding something wrong. It's not very high. So I've said 60% are caused by genetic abnormalities in the embryo with nature dealing with them, and then I might find 5% of causes. So there's still a big gap in the middle that we don't understand.
And don't forget that you can access all the previous episodes by going to our website www.theivfjourney.com and select IVF Journey podcast from the navigation menu.